Great, thanks Gary, and thanks Peter, and thanks for inviting me to come and speak to you on hyperadrenocorticism in dogs. It's rare in cats, so we're not really going to go there. And hopefully by the end of this talk, I will have enlightened you a little bit in terms of how to diagnose hyperadrenocorticism, and then also how to treat them. So if you've got any pressing questions as we go along, feel free to ask, or otherwise sort of wait until the end, and then we can actually, there'll be some time to ask some questions then. So whenever I look at a condition or ask to speak or something like that, what I like to do is actually go back in the literature, what we can find out in terms of actually who discovered the condition to start with. And autism, it's Harvey Cushing. So Harvey Cushing was probably one of the forefathers of neurosurgery, and this was back in sort of the end of the 1800s and early 1900s. And what he discovered, so he first reported a polyglandular syndrome in 1912, and then he actually published in 1932 8 cases, which we would now describe as having Cushing's in humans. He did various other things, that he took blood pressure into the States. He also improved survival after removing tumours from brains, which I think is pretty amazing in the sort of early 1900s doing that. And then also some other things of actually manipulation of the pituitary gland and how that actually affects kids in their growth, which I didn't really sort of delve further into that one, and how he came up with those conclusions. And then the next thing is to look at, okay, well, when did we first recognise Cushing's in dogs? And the first report that I can get was back in 1953, where they were describing alopecia and various other endocrine disorders in a few dogs. Okay, so what about cortisol function? So what we're talking about is hyperadrenocorticism is excessive cortisol. So what does cortisol do in the normal body? So we know that we need some cortisol. If we have no cortisol, then that's a bad thing. And then if we have too much, then that's a bad thing, but not as bad as not having enough. So I've got 3 images here. First of all, we've got Lorna Kiplagat, marathon runner, and there's going to be carbo loading. So in terms of talking about how it affects carbohydrate metabolism, it increases gluconeogenesis, so that from the proteins and other substances are actually converted in the liver and used for energy and formation of glycogen. And so what we're talking about is actually utilisation of protein, which is selectively taken away from the liver, as well as actually other protein within the body as well. So also in collagen, so you get atrophy of collagen as well. Then we've got Arnie in the middle here with the old protein shake and a few other things to help him along the way. And so the way that cortisol affects protein metabolism is that you have within the cells and within the muscle, we actually have protein metabolized from there and then actually taken to the liver. So we get muscle wastage. So that's one of the clinical signs that we'll actually see with Cushing's. Also, with utilisation of protein or less protein actually being produced, then the immune system actually suffers as well. And then finally, we've got the fat dude on the end here. And what happens with fat metabolism is there is actually an increased utilisation of fatty acid, which doesn't sort of quite fit with what we're seeing in Cushing's, although we do get a redistribution of fat. And we get redistribution of fat into the abdomen. And the mechanism of that isn't actually known. There's various theories, one being that actually the food intake is in excess of what is actually utilised. So, and then we get sort of a selective fat deposition within the abdomen. And then how is cortisol regulated? First of all, you've got to have a massive amount of stress or a little bit of stress. And then that has an effect on the brain, and that goes to the hypothalamus. And the hypothalamus releases the corticotrophin releasing hormone and goes through the microcirculation to the pituitary gland, where we then get ACTH released. The ACTH goes through the rest of the body down to our adrenal glands, and then we get cortisol released through that. Cortisol, that mechanism is actually very quick to occur. And as we get cortisol released, we then get the very important negative feedback effect where the cortisol actually inhibits the CRH and the ACTH that's released from the hypothalamus and from the pituitary gland as well. So that's what keeps it all in balance. Now, with Cushing's, there's different etiologies that we've got, and that's where either in the brain or in the adrenals that aren't actually functioning properly. So within the brain, and this dog here is actually an iatrogenic Cushingoid patient. So with pituitary-dependent adrenocorticism, in dogs, 80% of cases will actually fit into that category. And of those, some will be macroadenoma, so a small proportion of them are macroadenomas. So that means that the tumour is greater than 1 centimetre in diameter. And then the rest of them are microadenomas. Adrenal-dependent adrenocorticism is when we have tumours within the adrenal gland. So it's nothing to do with what's actually happening within the pituitary, but it's the adrenal gland that has a tumour in it, either an adenoma or a carcinoma. And that's releasing excessive amounts of cortisol. Pituitary dependent is releasing excessive amount of, or it's releasing ACTH, and there's a failure in that negative feedback effect. So even though you're getting a massive amount of cortisol being released from the adrenals, that negative feedback effect is no longer working. So you continue to actually have excessive cortisol released. In terms of the adrenal dependent, we're looking at about 20%. So 80% are pituitary dependent, 20% are adrenal dependent, and those are the ones where we're dealing with endogenous cortisol. But we probably have a higher number of iatrogenic cases proportionally. Would you agree with that, or not so much? And so this dog here, especially the big dogs, they really get this huge amount of muscle wastage when you first see it over those temporal muscles. All right, so what we're going to be looking at, presenting a case, and then we will have a little bit of a work through that. Now, we've got two cases here, and we might take a poll from the floor. On one of these patients has hyperadrenocorticism. One of them is polyuric and polydipsic, also has polyphagia, and has a pot belly. The other one has just come in for surgery, so I will do some pre-GA bloods on the patient, and we find that we have an elevated ALP. Who thinks this one's got Cushing's? Been clipped. Okay, so who would like to vote that the wee guy on the right has Cushing's? Okay. So what I'm trying to illustrate here is the most important thing to think about with these cases is what clinical signs that they've got. If they don't have any clinical signs, but we've just got an elevation in our ALP, those ones do not have Cushing's. Even if they do have Cushing's, we're not going to be treating them because the way we're treating them is by actually trying to treat their clinical signs. We're trying to get rid of their clinical signs. So even if he does have Cushing's, I'm not interested in it because I'm not going to be treating that patient anyway. So in order for us to actually check and go down the diagnostic route, then they have to have those clinical signs. So with all of the tests that we're actually doing with our patients, we're trying to back up what our clinical diagnosis is. So we're trying to support that. All right, so this little doggy here is Stella, and she's an 8-year-old female border terrier. So that's a pretty typical signalment that we're getting with these patients. Generally, dogs with Cushing's are greater than 6 to 8 years old, so any patient that you're looking at that's actually less than that age need to look for an iatrogenic cause of Cushing's. And there's various sort of iatrogenic causes. One would be that we've got them on steroids because they've got fleas. Another reason maybe so they may be tablets that they're getting. They might be getting depot injections. they may be getting topical steroids. And then there also has been a case report of actually an owner, actually they had cortisone or had been treating themselves with hydrocortisone, and that was actually getting rubbed off on the dog, and was diagnosed as having iatrogenic Cushing's. So the majority of these patients are old. In dogs which have pituitary-dependent hyperadrenocorticism, they greater than about 75% of, so there'll be sort of 75% of dogs will be older than 8 years. In dogs with adrenal dependent, 90% of them are actually older than the 9 years, with a median of around about 11 years. So we're looking at older dogs with this condition. Females are overrepresented, and they make up about 60% of cases that we see. The pituitary dependent, generally those dogs are smaller, and 75% of dogs with PDH are less than 20 kilos, whereas those with adrenal tumours, half of them are bigger than 20 kilos or weigh more than 20 kilos, and half of them weigh less than 20 kilos. All right, so this is the typical history that we would get with patients. And what we look at, most dogs won't have all the classic signs of Cushing's, but we need to probably have at least two that we're concerned about. And with Stella, we had polyuria and polydipsia, and that's thought to be through central diabetes insipidus, where ADH isn't actually released. So we need the antidiuretic hormone to have an effect on the kidneys so that we get concentrated urine. That's not happening, so we get dilute urine, and then we get polyuria because of that, and then a compensatory polydipsia.
Why is the ADH?
I don't think they really know why it's not released, but they've found out that it isn't released, yeah. Polyphagia. It's seen in dogs, but it's actually not seen in humans, and it doesn't seem to be seen in cats in the few cases that are reported as well, which I think is quite interesting because with stress, if I get a little bit of stress, I get polyphagic, a little bit more stress, and then I stop eating. So I don't know if anybody always wondered if that was a cortisol that was being released. Then we have a pot belly is quite a classic sign as well, and there's various reasons for that too. One, we're getting a big liver because of the glycogen that's being stored there. We've got muscle weakness because of the interference and the mobilisation of the protein within the muscles. We've got a big bladder because we've got increase in urine production. And then we've also got the fat deposition within the abdomen as well. So it's quite a classic potbelly appearance that we get. Often the dogs will be lethargic as well. And again, that may well come down to them actually having muscle weakness, and then they're going to have exercise intolerance with that as well. Now, typically, in a normal case with Cushing's, I'll be thinking about the 5 Ps. So potbelly, PU, PD, polyphagia, and then panting as well. So often actually, this dog didn't have a history of panting, but often we'll find that they'll be panting as well. So in the history, we always want to get a good history on what drugs have been taken. That may be in your clinical notes because you've seen the patients before. But also actually knowing of what other topical treatments are actually given too. One would be arnica. Sounds like some of the arnica products that are brought in may have a little bit of steroid in them as well. Okay. So, yeah.
Can you just clarify for me the protein breakdown? Is that because it's converted into glucose?
It's converted into glycogen. So it gets mobilised, taken to the liver, it goes through the gluconeogenesis, and then we get glycogen formation. Yeah. It also has an effect on skin, so it affects the growth and it inhibits the growth cycle, so we get alopecia. We can see a little dog here with non-pruritic alopecia. You may have a pyoderma associated with it as well. So if you've got calcinosis cutis, then they can have a pyoderma associated with that as well, with some of the skin breakdown and things that they have too. And then also because we've got suppression of our immune system, again, these patients will be more susceptible to getting a pyoderma. The mechanism of calcinosis cutis isn't isn't known, but we do get deposition of calcium, and then we can get mineralisation in other areas of the body as well. There's increased fragility of the skin, and then also wounds don't heal as well as they should do either, and that's the effect that it has on the collagen. So we get a reduction in the protein, so that means a reduction in the collagen, and that will increase fragility within the skin as well as actually within the blood vessels as well. So when you actually come to bleed these guys, no bruising initially, but you bleed them, and then often you may be left with a big bruise afterwards. Reproduction is affected because, as well as having the cortisol having a negative feedback effect on your ACTH and your CRH, it also has a negative feedback effect on the gonadotrophin hormones too. So in females, you can have anestrus. In males, you can have testicular atrophy. It's not something that's really recognised by the owners. One being that most of our patients, females anyway, will be spayed, and then there's probably not a lot of owners who are going around feeling their dog's testicles. So in terms of neuromuscular changes, those are rare. We don't often see them, but we do see them in some patients. So one, we can get muscle weakness, and I've seen patients to the point that they've got muscle weakness that they no longer can actually get up. There is a pseudomyotonia that they can get, which they get really stiff in their hind limbs. And then sometimes we'll get changes because of a macroadenoma within the pituitary. So got a big brain tumour, increase in your intracranial pressure, and you're going to start seeing changes like head pressing, circling, various other neurological signs which are suspicious of a tumour. So the physical examination that we had on Stella was that she was quiet. She had a pot-belly appearance. Couldn't really get a good impression about whether the liver was big. And then what we also noticed that her hair hadn't grown back particularly well over where she'd had an ultrasound a couple of months prior to her coming back in, and that hadn't regrown. So on clinical examination, we might pick up that there's hepatomegaly. We'll see that the skin changes, testicular atrophy in males, and then the bruisability. All right, so what are we thinking about when we're talking about sort of differentials? So I was going to have sort of a huge long list of different things that it can be. But in terms of actually what we're really thinking about, we're talking about PU, PD, we're talking about polyphagia. And with those, there's not a lot of things that can actually cause those clinical signs. And one would be Cushing's, the other would be diabetes mellitus. And then we will also see phenobarbital can cause similar clinical signs, but hopefully with a good drug history or your clinical notes, you'll have that information whether the dog's been on phenobarb. And I've got a picture of a urine sample here, because the one thing that may kill this dog is whether it's got diabetes. Cushing's it's very rare for dogs to actually die of Cushing's, but it's very important to recognise whether they've got diabetes, because if we don't recognise that, then they can die because of that. So it's very important to get a urine sample. It's very easy to do. It's very cheap to do. So to actually rule out something that could be life-threatening for the patient is going to be the top priority. We can look at a whole lot of other differentials that could be causing PUPD, so renal failure, various other things. But in terms of actually having the classical symptoms, we shouldn't be seeing that. And again, polyphagia, there can be different differentials for that, but a dog that has apparent weight gain, doesn't seem to be losing weight, and polyphagic as well, there's very few other things that could actually cause that. Oh, sorry, that hasn't come up. So the next thing that we need to look at doing is, if we're suspicious that this patient actually has Cushing's, then we need to look at further tests that we do. So we're trying to put more weight into the diagnosis that we're making. The majority of patients that we have coming in, the owners don't actually perceive as being ill. They don't come in vomiting, they don't come in with diarrhoea or collapsing. So the owners feel that they're well. They are slowing down, but these are older patients, so they're putting it down to that these patients are getting older. It's just age-related. But as we know, age isn't a disease, although we're trying really hard to actually cure it. So once we've established that the clinical signs fit with this disease, then that's when we're going to go on and do some further tests. And we can do, majority of times we'll be looking at doing hematology and biochemistry, and there's probably very rare occasions where we wouldn't do that, and that will probably come down to a financial issue. And on the hematology, what I'd be looking at is the hematocrit. So often when dogs are sick, you'd expect them to be a little bit anemic. So anemia of chronic disease, you're going to have a mild anemia, whereas these dogs, hematocrit, if anything, is a little bit higher than what you would expect. The other thing that I would look at is the platelet count. And for an unknown reason, the platelets are often actually increased. Now, the thing with Cushing's is that one of the rare complications that we can have with them is thromboembolic disease. And again, the mechanism of that is not totally understood, but whether this has a part to play in it with an increase in our platelets. It's also been shown that the coagulation factors are actually increased as well. And then looking at our white blood cell, and unfortunately some of them have dropped off the end, looking at neutrophils increase. So we're looking at the classic stress response with these patients. The way I kind of think about it is that with diseases of lymphocytes or diseases of eosinophils, I'm going to be treating those with steroids to get them down. So with a patient that's got Cushing's, I'd expect the lymphocytes and the eosinophils to go down. And you can sometimes actually, with Addison's, actually see an increase in your eosinophils. And then you get an increase in your neutrophils, your classic stress response, as well as actually getting an increase in your monocytes as well. So on our biochemistry, what would we expect to see on that? The classic changes, and what we always talk about, is our increase in ALP. So a couple of mechanisms for that. It's the induction of the ISA enzyme, as well as we're getting glycogen going into the liver as well. We're getting some swelling. There's going to be a little bit of cholestasis going on. So we may be getting a little bit of an increase in our ALP because of that as well. With that swelling, we may get a little bit of damage to those hepatocytes. So it's not unusual just to get a little bit of an increase in the ALT. So generally, you're only looking at a mild elevation in your ALT. Proteins can sometimes be increased. And then because of the lipolysis, we will get an increase in our cholesterol as well. Always look at our glucose, because 5% of these patients will actually develop diabetes mellitus as well. So we want to know that that's normal. And the other thing that I would say is, as you go through treatment, or if there's actually a delay in treating these patients, get a glucose done. In terms of just getting a urine sample, it's really easy to do and is very important for the patient. Urinalysis is very important, and the changes that we'll see with that. So one, we're looking at the glucose. That would be the first thing that I look at. Make sure that it's negative. Urine-specific gravity is sort of lowish. Around about 10-20 is fairly typical. And then often we'll find that our proteins are slightly increased as well. So it's quite unusual to have a proteinuria, or it's likely to be more significant if you've got a proteinuria as well as a low specific gravity. And with your proteins, you're going to be thinking about a couple of things. One is to do a culture and sensitivity. 50% of dogs with Cushing's will have a urinary tract infection, so we'll get a urine sample to check for that. There's generally no other signs because you're dealing with an inflammatory, an anti-inflammatory effect of the steroids, so you may not have any clinical signs of that as well. The other reason why we might have an increase in the protein is because of an increase in blood pressure. So we've got hypertension as well. And so hypertension's doing damage to the glomeruli, and with that we're getting a loss of protein. Usually that resolves as you start treating the patients. So we used to take quite a few radiographs. So before the advent of ultrasound, we used to take radiographs. So one, I'm sorry about the quality here. One here you can see on this doggy that the patient's got a big liver. We're seeing a little bit of a bladder coming in there as well. With dogs with adrenal tumours, whether they're adenomas or carcinomas, 50% of those will be mineralised. And so with those patients, you may actually pick that up on the radiograph. And when I was in the UK, we always used to take radiographs of the chest as well. And we see changes with mineralisation either within the tracheal rings, within the bronchi as well. And that can be one of the reasons that we get panting in these patients. Also, we've got increased pressure down here with all of the abdominal organs and the muscle weakness of the diaphragm and the intercostal muscles. And again, that can all cause some panting. Less likely would be something like a PTE that we'd be dealing with. Although I might have been suspicious in a couple of cases, I haven't diagnosed a PTE in a Cushingoid dog. Has anybody been suspicious of one in a Cushingoid dog?
Post-op death.
Yeah. Yeah, so that's when most of the risk would be, is when you're actually operating and removing an adrenal tumour. Those dogs have a high risk of developing a thrombus afterwards. The other reason that we would look at doing chest radiographs as well is looking for metastases. So pituitary tumours don't metastasise, whereas adrenal tumours, there is a small proportion of those dogs that will actually metastasise. So we're looking within the chest, because if we're getting mets in the chest, that's going to change what we plan to do. So most of the cases that we'd be looking at, we'll do abdominal ultrasound. So even if you're not referring to somebody to do the ultrasound, whether it's a medicine specialist, generally what you're going to, you may get Chris to actually do an outpatient ultrasound to see whether you've got adrenal enlargement. So what you're going to be seeing, so this is the left adrenal here, which is the peanut shape of the adrenal. Normal size should be less than about 7.5 millimetres. So anything above 8, you're getting suspicious that you may have Cushing's. But we're also looking at both adrenals. Are both adrenals enlarged, which is going to support it being a pituitary dependent? Or is it just one adrenal enlarged, the other one may be normal, or it may be smaller? And in that case, then you're going to be looking that's supportive of it being an adrenal dependent. If you can't identify your adrenals, then it may well be that you've got iatrogenic. But with all of that, doing ultrasound is very much operator dependent. And you've got to be sure that the person driving the probe is going to be giving you good, solid images and advice. Also, on a patient that we're suspicious of having Cushing's, the other thing that we're looking for is what's happening in the liver. Usually we're getting the hyperechoic liver, and that's just because of the fat that's within the liver, or with the glycogen that's in there. It comes up brighter than normal. We're also looking for metastases within the liver as well. So metastases can go to the liver, can also go to the lungs. Now, put in there incidentaloma. What do you do in those patients? So we do ultrasound a lot of patients, and invariably we have a few coming up each year where we've got a little mass on the adrenals. So what do we do? If it's less than 2 centimetres, then that's probably more likely to be benign. Those that are bigger than 2 centimetres could be malignant. Those that are bigger than 4 centimetres are most likely to be malignant. So if we've got something that's sitting there less than 2 centimetres, then we'll advise to come back in 4 to 6 weeks. We'll repeat the abdominal ultrasound and see if it's changing. If it's not changing, then we just monitor it and see how it goes, and do sequential ultrasounds, say 3 to 6 months later. If it's growing, or if it's large, if we've got invasion of other blood vessels, or something that's looking very irregular, then we'll look at actually removing it with surgery. Now, there have been a whole bunch that they've found these incidental masses on the adrenals, and then they've actually followed them through to necropsy. They find that 30% of them are granulomas, 30% of them are not, actually nothing's found, they're completely normal, and then about 40% of them come back as phaeochromocytomas. So whether phaeos are clinically quite difficult to actually diagnose, and whether they were actually causing a clinical problem for the patients is unknown. All right, so moving on to the different screening tests that we all do. So before we go on to that, again, the most important thing to say is, do we have the clinical signs for Cushing's? If we don't have the clinical signs, then we're not going to be doing any of these tests. So we're only doing these tests to support our suspicions on our clinical examination. We can look at doing a urine cortisol creatinine ratio. Got the ACH stimulation test, and then also a low-dose dexamethasone suppression test. So in Stella, looking at her urine cortisol to creatinine ratio, the reason that we look at doing that is really trying to rule it out. So if we get a negative result with that, then in the most cases, the majority of cases, we should be able to actually rule Cushing's out. If it comes back positive, then we don't know, does it have Cushing's or does it not have Cushing's, but it gives us more information in terms of, do we go on and actually do some further tests. So less than 10 is normal, 10 to 15 is suspicious, and then greater than 15 suggests Cushing's. Although I wouldn't make a diagnosis of Cushing's off this test, I would make a diagnosis of another test. So basically you're only trying to do this one if you're really trying to rule Cushing's out. And then the next question is, do we look at doing a low-dose DEX test, or do we do an ACH Stem test? So we'll come to our second poll. Who does ACH Stems as their first test? Sorry? Yeah. You're only as good as your last test, really, aren't you? Okay, so who does low-dose DEX as a routine? Okay. So in terms of, they got a bunch of endocrinologists together, and they had 5 of them, and they had a discussion about whether you should be doing your low-dose DEX as the screening test or whether you should do your ACH Stem. So 4 out of the 5 said you should always do a low-dose DEX, you shouldn't be doing an ACH Stem, whereas there was one person who said that routinely they would do an ACH Stem and they wouldn't budge on that. So they haven't been able to give the recommendation that you should always be doing a low-dose DEX, but the people are quite opinionated whether you should be doing a low-dose DEX or whether you could be looking at doing an ACH Stem. So in terms of the ACH Stem, the advantages of it is it's really easy to do, it's really quick to do. So you get your cortisol level, so your T0, and then you give your synthetic ACTH, and then an hour later you pull your next blood test to get your next cortisol level. And what we're trying to do is stimulate those adrenals as much as we can to see how much cortisol they can actually produce. One, I find it much easier to actually interpret that than a low-dose DEX test. It's also much quicker to do, and you can get them in the morning. You don't have to have them the whole day, and you don't have to worry about them actually getting stressed within the clinic as well. The other advantage of it is that you can actually diagnose iatrogenic Cushing's off it. So if you're giving steroids exogenously, that's going to dampen down what's happening with your adrenals. Your adrenals will atrophy. They won't be able to produce that much cortisol anyway, so you end up with a flat line. You can make your diagnosis off that. The ACH Stem is also how you do your treatment monitoring. So I also like to have a baseline, but actually you don't need to have your baseline with your ACH Stems. Okay, so this is what we got in Stella, and down at the bottom here we got about 150 nanomoles per litre. We gave her the ACTH, and then we got that up to around about 900. Now, she had clinical signs that were supportive of it, and so with all of that put together, we're happy to make a diagnosis of Cushing's. Now, the reason why there's a difference between people's opinions on whether to use the ACTH or whether to use the low-dose DEX is what the sensitivity and specificity of it is. So with your ACTH Stem, you're going to be picking up about 80 to 85% of your pituitary-dependent Cushingoid patients. But with it only picks up about 50% of the adrenal-dependent ones. Whereas with your low-dose DEX, reckon that it's probably about 100%, so between 90 and 100% of sensitivity of actually picking up your PDH as well as your adrenal-dependent Cushing's. Why in the past I've liked ACTH better was I felt that there were less false positives with it. Felt that with a low-dose DEX that you got a higher proportion of false positives just because of the impact of stress and things with it. But I think if you following on from the fact that we're only testing those patients that we have a high clinical suspicion, then actually those false positives should lessen. Okay, so with the low-dose DEX, the protocol that we're using is you get your pre-treatment level, then we give the dexamethasone IV, so it's a low dose, and then we recheck at 4 hours and then 8 hours, most important being your 8-hour level that you're getting. It works on the principle of the negative feedback effect. Okay, so if we go back to the chart we had before, we know that there's this failure. So when we've got a pituitary tumour, it is no longer suppressed by cortisol going back. So that's what the basis of the low-dose DEX is, that it's actually working normally, then we're going to get that negative feedback effect and we're going to get a drop in our cortisol. But what's happening with these patients is that negative feedback effect doesn't work any longer and we don't get suppression of our cortisol level. So the advantage of it is that it's very sensitive. And the other things in humans use the ACH Stem, so they use a stimulation test to diagnose an endocrine problem that's low, so high pose, whereas they actually use the suppression test for anything that they're concerned that there's excessive hormone. The other advantage of the low-dose DEX is that we can use it it will help in discrimination in some of the patients that we see. But I find that the disadvantage of them is time and also the concern that they may well be affected by stress as well. All right, so interpretation.
What do you mean by that? If they get stressed, it's false positive?
Yes, if they get stressed, you potentially can have an increase in your cortisol because of that. So I'm concerned about getting a false positive with it. Yeah. But as I said, if you're dealing with patients that you've got high suspicion of it, then those cases should lessen. So if you're doing a low-dose DEX and any patient that comes in off the road that you're not concerned that it's got Cushing's and then you do the test, you're going to get some false positives because of that. But if you're dealing with a patient with a high suspicion of Cushing's, then you won't get as many false positive patients.
Has anyone done a study on that to see the stress?
Yeah, so they have done sensitivities and specificities on it as well, yeah. But it depends on what patients you're actually testing to. So is it ones that have some other stressful disease going on? Is it a healthy patient? Or is it a patient with Cushing's? Yeah.
Do you think the ACTH stem is affected by stress?
It's not affected in the short term with stress. So yes, it can also. So you can also get false positives with ACTH stems as well, but maybe not as high, and it doesn't get affected as much with the short term stress. So the stress of being hospitalised, because your adrenal glands haven't had time to get hyperplasia. Does that make sense?
Is the ACH stem used to do it at 9 o'clock in the morning, is that still relevant? Or
No, I don't.
circadian effect of the cortisol?
Well, it shouldn't affect that because you're trying to stimulate those glands to see how much they potentially can produce. So it's not going to really matter what point in the day that you do it. Yeah, but you're right. There is a diurnal variation on that. Yeah. In terms of that's why you don't do just a baseline. So we don't just do a random cortisol in patients with Cushing's because that's not going to give you, that's not going to give you much information. So this is a low dose DEX test. So the initial one, the baseline that we got was about 51, and then the first thing that we look at is that 8-hour one. So does this patient have Cushing's or does it not have Cushing's? So what we use is our cut-off of 40 nanomoles per litre. So if this is less than 40, some labs I think use less than 30. Catherine, do you know what? Are you using less than 40? Yeah, Wibbles is the same. In the States, they will sometimes use less than 30. So there is there is a grey area between 30 and 40. So at 8 hours, we're looking at, is that suppressed or not? If it's suppressed, then it's normal. If we don't have suppression, then that's abnormal. We've got a failure of that negative feedback effect. So we use the 8 hours, so the 8-hour one to see whether we've got Cushing's. The 4-hour one is to use as a discriminatory test. So does it work quickly and have an effect? If it does actually suppress below that, then we could be looking at a pituitary-dependent hyperadrenocorticism. You can't, if it doesn't suppress at your 4 hours, then it could be either ADH or PDH. So in terms of who does discriminatory tests? Does anybody look at doing discriminatory tests? Do you worry about that? Yeah. Yeah. And I think, just with the access that we've got to abdominal ultrasound in terms of actually how much information that we're going to get from it, then yes, I'd look at actually doing an abdominal ultrasound. If we get a little bit more information from the low-dose DEX, then that's probably useful, but very rarely would I go for a high-dose DEX test. ACTH assays are available overseas, not available here, and I don't know if they will, but you do them?
Yeah, we just started, we live in horses and we just only get some.
Okay. Cool. Oh, gosh. Yeah. Freeze it. Yeah. So in terms of the information that we get, we're going to get most of that information off an abdominal ultrasound, including further information in terms of have we got metastases within the liver. And prior to, so what I'd say with any test, is it going to change what we do? So in terms of a discriminatory test, is it going to change what we do? If a patient you've diagnosed with Cushing's, but they're not going to go for surgery, then you've got a question, well, is it important then to know is this adrenal or pituitary? But obviously, if it's going to change what the plan is for that patient, then it's very important to do it. All right, so in terms of treatment, so you can treat both pituitary and adrenal with surgery. And whenever I think of pituitary-dependent hyperadrenocorticism and surgery, which is a transsphenoidal approach, I always think of Total Recall and Arnie pulling something out of his nose. And they have an approach through the nose and actually remove the pituitary gland. They do it in Holland frequently. That's their treatment of choice for pituitary dependent. And reading text, often they'll say actually the best treatment would be to do the surgery, remove the pituitary, with a small caveat there that it has to be with an experienced surgeon and one that's actually done several procedures beforehand. So there's a bit of a steep learning curve with the old pituitary surgery, in that there's obviously sort of a high mortality rate when the surgeon starts out. So it's quite a hard route to go down, and I don't know of anybody in New Zealand who would be doing it or willing to do it. Obviously, with ADH, that's a treatment of choice, if at all possible, to actually remove them surgically. Owners won't always go for surgery. There may be some other reasons why surgeries, why we don't go down the surgical route. Either there might be some concurrent problems, or we may have metastases as well, where we then don't want to go down the surgical route.
How common are metastases?
It's about 10% of patients, yeah. I mean, often, we'll take, so before surgery, I would always do chest radiographs, and we'll see on some of those patients that there might be metastases there. It doesn't necessarily actually metastasize from the adrenal tumour, but it means that I wouldn't send them to surgery. We don't biopsy masses within the lungs of the...
ones that are locally invasive into blood vessels. Where's your cut-off point?
Well, I think think people are recommending now that those ones should probably go for surgery. So I think you've got to have a good chat with the owners about that one, and then obviously talk to the surgeon and see if they're happy to do that. Yeah. But I mean, the tricky part actually with the surgery and removing that is, again, you want an experienced surgeon doing it, and the perioperative period is very important in terms of you removing that adrenal. The other one's atrophied, so it's going to be a while before we get cortisol released from that, so you've got to ensure that they don't become Addisonian. And then also there's a high risk of them getting a thrombus as well, so that's the other risk factor. So those two aspects need to be managed with medication and things as well, yeah. So as a medic, way that what I'm looking at is the medical treatment of using Visceral or mightat. And obviously here with Peter tonight, we're looking at Visceral, but mightat sort of historically has been what we've used. So who uses mightat? And who uses trilostane or Visceral? Yeah. Yeah. So we've sort of, over the last couple of years, have kind of been fluctuating with what we've been using. So initially we were using trilostane, then trilostane was going out, so then we were back onto sort of using mightat and kind of phasing out all our patients on trilostane. Now I think we're moving more going down sort of the Visceral route because of concern about whether they're going to have access to mightat as well. So it kind of sort of fluctuates, it comes and goes. Okay, but Visceral is a competitive inhibitor of the 3-beta-hydroxysteroid dehydrogenase, which is this enzyme in here. So we have inhibition of this enzyme, and then that blocks that pathway in terms of actually getting cortisol produced. So we ultimately end up in a reduction in the production of cortisol. It does have an effect on some of these other hormones here as well, which can be important in some of the atypical cases of Cushing's that we might see. All right, so the starting dose, initially the starting dose was thought to be higher. So when they first started out, probably about 15 years ago with using trilostane, the dose that they had was actually higher than that. But now it's recommended that your starting dose is about 2 mg per kg, and that's once daily with food. Some people go twice daily, and if you're going twice daily, then you're starting at 1 mg per kg BID. The way we go about monitoring is doing an ACH Stem test, and that's 4 to 6 hours after the pill. Yep.
Isn't that recommended because it's the short half-life?
Yeah, so that's one of the... I mean, I still go once a day, but so what we don't... So there's a lot of variation between dogs and how long it's actually effective for. There's some, so it's probably anywhere between 10 hours and 18 hours, but it probably has worn off within that 10-hour period, yeah. But I still start them on once a day. Are you starting them on twice a day? Yeah. And then after 1 week, we do an ACH Stem. And the main thing we're looking at on that is that we're actually not overdosing the patients. So we still get an effect as the patients are treated with the Visceral up until a month. So that 1 week, at that 1 week check, what we're looking for is that we don't want those patients being overdosed. We don't want them to have plummet in their cortisol and then have a problem because of that. So that's what I'm checking at that 1 week, 1 week check. Then at 1 month, another ACH Stem, and that's the point that I'll actually increase it or decrease it if necessary. And then at 3 months, doing another check and checking that we're on the right level of our Visceral. Now, very important client communication with these patients. Obviously, if we overdose them or they have some other problem, and that goes for any medical management, these patients can go into an Addisonian crisis. So it's very important that they actually realise what to watch out for with these patients. We'll always look at treating them at home and also look at regular contact. So we try and get our nurses to actually ring the clients once a day and just make sure that everything's going okay. So how are we going to interpret what we're getting back on our ACTH stems? So our target is between 40 and 150 nanomoles per litre. And if we're reaching that on our post-stim sample, then we're not going to change anything. Then the next values that we're looking at are between 150 and 250. So if it's less than 250 and we're getting a good resolution of our clinical signs, then again, we're not going to change things. We're going to just see how things go. But if the level is greater than 150 and the clinical signs are unchanged, then we're going to increase our dose. So we're going to do it cautiously and increase it by about 25%. Obviously, the one of major concern is if we're getting less than 40, we're going to stop our drug. We're going to leave it a few days, if necessary, supplement with steroids, and then we're going to do an ACH stem before we actually start up with the drug again. We're going to decrease the dose by 50%. We're going to recheck what's happening with our ACTH stem about 10 to 14 days later.
At your 1 month check or the 1 week check?
So I would do, so basically at the 1 week check, we're just making sure that we're not going too low.
Right.
Yeah. So more our change is going to be done on that 1 month check. Obviously, if we're going too low at that 1 week check, then yes, we do reduce it or stop the medication and reduce it, yeah. Okay, what we're going to get our owners to monitor is appetite. So we want it to go back down to a normal appetite. So these patients are ravenous. We want it to reduce. We don't want it to reduce to the point that they're becoming inappetent or anorexic. We also want them to watch out for any vomiting or diarrhea and lethargy. And then also looking for sort of undue weakness. So some of these patients will be lethargic when they present, but you don't want them to end up being collapsed. And it's very important to reiterate that to the clients. Send them home with a discharge form, drug information as well, because that's obviously a very important thing to actually pick up. If anything like that happens, stop the medication. And that's more for the owners rather than you guys. Okay, so in terms of the response to treatment that we get, so we want to get back to an aged but bouncy border terrier. And the response to treatment, many of the signs will quickly become controlled, and 75% of patients by about 4 weeks will have their PUPD controlled. Generally, the dermatological signs and some of the more chronic signs that have come on will take months to actually resolve. So you're looking at about 3 to 6 months for those to actually resolve. Now, a couple of things to just think about. One is there's been a couple of case reports of adrenal necrosis. And so usually with Visceral, because we actually interfering with the enzyme, usually when you actually take that away, then actually the cortisol level will come back pretty quickly. But there are some cases where you actually get adrenal necrosis. Exact mechanism, again, is not quite known, but basically you get destruction of the adrenal gland, and those patients will go into an acute adrenal crisis, and they won't get their adrenal function back. There are also a small proportion of patients that won't respond, are resistant to treatment as well.
Just with that, Robyn, with the adrenal necrosis,
yeah.
There's a school of thought that thinks it could be the ACTH,
yeah.
like the endogenous or from the ACTH stem test. Is that?
I think probably, so what I've read is probably more from the endogenous.
Right.
So, yeah, with the PDH, you've still got your massive release of your ACTH, and that might have an effect, yeah. But it's rare. I mean, I've only sort of seen a couple of case reports of it, yeah. So the other option that we've got is mightat, so OPDD. And the way that works is you get necrosis of your adrenal gland. Treatment protocol, and I've always found this just harder to get my head round, or actually at the point of when do you actually stop giving the mightat. So we're looking at a loading dose, and that's usually 5 to 9 days that will be required. There's about 10% of patients that will be going longer than 9 days. If you're going weeks, then you've got to go back, re-look at what your diagnosis is. This may be adrenal tumour as well, and it may at that point might be worthwhile to say go for an ultrasound and see if that's why you've got some resistance to to it working. Once you've done that loading dose, then you back off and you go on to your maintenance dose.
Sorry, Robyn, with the adrenal tumours, do you use a double dose to start with?
No, not to start with. So with adrenal, so first of all, with an adrenal tumour, my first thought would be to send it to surgery. So that would be my preference, if that's at all possible. If that's not possible, then consider trilostane or mightat. So I would also potentially treat them with trilostane as well, with Visceral. With mightat, I would start them on a normal dose first, and then see how they respond. If they're not responding to that, then you can look at actually increasing your dose after that. So you give them a period of 9 days, see how they actually respond. Do your ACH Stem, look, and if you're not getting a good reduction in what your ACH is doing, then you could actually increase in your dose. Yeah.
Because I've treated in the past with using the higher dose, and I think Nelson and Club suggest using the higher dose for adrenal tumours.
I mean, I think the main thing here, and that one, we don't want to do any harm. So with these patients that come in, as I said at the beginning, they're generally not well. The owners don't perceive them as being unwell. So that goes back to the principle of doing no harm. So I think starting out cautiously would be the thing to do. I mean, the issue is that you can kill them with putting them on high dose mightat. So I would start cautiously, yeah. The other thing, that there's two schools of thought as well, is whether you actually send them home to have them treated at home or whether you actually keep them in the hospital. The problem with having them in the hospital is that they don't do their normal things. They don't drink probably as much as they should do. And also you don't know them as well as the owners, so you don't know what their appetite is like normally. Whereas the owners are generally very good at picking up those sort of subtle changes that we're really looking for, especially with the mightat. Again, we're looking at the owners monitoring exactly the same as with Visceral, monitoring what's happening with their appetite, water intake, activity, and their attitude as well. So with their appetite, we're looking for just the slightest drop-off in their polyphagia. So they're generally ravenous, and we're just looking for that slight back off, that they will actually lift their head when the owners speak to them, or something else that's actually quite subtle that the owners will pick up. You also tend to reduce the amount that you actually feed them. So instead of feeding them the amount you normally would, you reduce it to about 2/3 of normal. So you make them ultra ravenous, so that you can then pick up when's the point to actually back off. Monitoring water intake as well, but that's not necessarily as reliable. And then with activity and attitude, we're really looking to ensure that they're not becoming Addisonian.
Why are you so worried about making it Addisonian? Because some people actually use that as their method of treatment.
Oh, it is, yeah, and that's
So they
that's
think it's
yeah.
actually preferable to make them Addisonian and then treat that.
Yeah, no, and some people do have that opinion. My concern with it is that, again, you potentially would kill the patient by doing that.
Especially
Yep.
if they've got lost and didn't take the medication.
Yeah. So I mean, that's kind of my rationale. If they miss some of their medication when they've got Cushing's, it's not such a big deal. Yeah. So we're looking to any loss of appetite, drinking reduced to we would consider as our daily, the animal's daily requirement. Any vomiting or diarrhea, and listlessness as well. So when you're thinking of a patient that comes in sick, you've started them on either Visceral or mightat, you're thinking, okay, it's coming in sick. Is it because of the drugs that they're getting? So mightat can cause a little bit of GI irritation as well, so it's actually the effect of the drug that can specifically do that. With Visceral and with the two drugs, as you get sort of a drop in your cortisol, you do get a little bit of a withdrawal from that. Obviously, the concern is that these patients might be Addisonian, but you've also got to think, is it actually something else? So one, you need to make the diagnosis about why these patients are actually unwell, because there could be a concurrent disease going on, one being diabetes. Sorry, yes? In terms of is it polyphagic? So polyphagia will be seen in about 80-90% of patients, and similarly PUPD is 80 to 90%. So you're not going to see it in all your patients, but you're going to see it in the majority of patients. So it depends on if there's any other clinical signs. But sorry, can you just go through those clinical signs again, Gary?
Well, the polyphagia is not easy to read always as well.
Mm-hmm.
So, if the water, what I'm saying is if the water polydipsia is not really clear cut,
Mm-hmm.
would you even investigate the possibility of a Cushing's, knowing that you can get false positives anyway?
I would.
Track, or would you just
No,
stop
I wouldn't.
before that?
Yeah, I would stop before that. So if I haven't got good clinical evidence that that's what's going on, I know there's a lot of different. Yeah. Or that I'm not convinced that it's polyphagic. I mean, if it's polyphagic and has alopecia bilaterally that's non-pruritic.
But all like that.
No, they're not. No, but then it comes down to, it doesn't matter if they're not treated. If we're saying that generally these dogs are very well, we've got time to wait. So it's not like we're dealing with a diabetic patient that needs treatment. These guys don't necessarily need treatment.
In
So,
fact, we often tell them we're suspecting it months before they want us to even look at it.
Yeah.
And they only really worry about it when they start peeing inside at
Yeah.
night time.
Yeah.
But we were often worried about it months and months before that.
Yeah.
Because
Yeah.
they're sitting in our room panting away.
Yeah.
But it's not an urgent thing.
No, it's not, and you've got time. So you give them time, you give them a couple of months or how much they need. And as you say, it's often when they've been drinking excessively and they don't initially notice that. It's just the inappropriate urination or being woken up in the middle of the night and wanting to go out, yeah. All right, some people will start on Sunday, and then you'd hope that by the end of that week that you're going to start seeing a reduction in appetite. If you're not seeing a reduction, then automatically actually do an ACH Stem on the Monday. Once you get to your maintenance level, you're going to be retesting once a month, and then after that, you're looking at every 2 to 4 months. You're looking at it, again, very similar with the two drugs in terms of you're looking at days with PUPD and polyphagia resolving. You're looking at weeks with muscle strength and a change in the potbelly appearance, and then months in terms of your skin changes and hypertension. Hypertension isn't always resolved, so there's probably another reason why some of these patients are hypertensive. So I think the most important thing is to ensure that the clinical signs are consistent with the diagnosis or the tests that you're going to do. Actually, we should be looking at doing low-dose DEC suppression tests, but there are a lot of reasons why we do the ACTH stems. And then once you initiate treatment, it's very important to just have very close client contact, just ensuring those patients are doing well. Okay, so this is another couple of Cushing patients that I've had. This little guy down here, and then we had a big Dobie, which you don't often see Cushing's in. Okay, so I'd like to thank Peter for inviting me to speak, and AVS for having me. And does anybody have any questions?
Back to Visceral, how often do seagulls get overdosed? 2 minutes.
Not when they first, so sort of back sort of in the sort of early 2000 time, we're using much higher doses, so actually the frequency of having problems then was higher. But I think now sort of having backed off on that, not seeing them as frequently. So I think looking at both mightat and Visceral is very similar in terms of the problems and side effects. And the proportion that you have with them, yeah.
What sort of time would it be? Is it more likely to be 3 or 4 weeks before it gets to those?
It can be any stage. Obviously, the first week or so would be the most concern, but probably in that first month would be really important. But after that, they still need to be monitored in terms of the owners just keeping a close eye on them. Yeah.
Do you get, say, an indication of what the first ACTH test results are, as to whether they're more likely to go low after that test? Responding quite quickly, perhaps? Would you say they're more likely to be more sensitive?
Well, so yeah, I mean, they probably will be more sensitive, but you want to get them onto a maintenance rate anyway, and they'll probably, once you get them onto a maintenance rate, they generally do all right. Yeah.
Why is it that cats are poorly represented?
I don't know the answer to that question.
They've got smaller brains with the children get bigger.
I think that usually cats with Cushing's will be diabetic as well, so it usually they go hand in hand. Yeah. Yeah.
So it's more the diabetics we can't control when we go looking for the other.
You often know. So if you get a Cushingoid cat, you know they get the very thin skin, and the skin starts tearing and things as well. So it's actually sort of quite a dramatic. And yes, as well as actually having resistance to the insulin. Yeah, yeah.
How do the adrenal tumour ones go with the Visceral?
They do okay. So there have been some case reports of actually using it with adrenal tumours. So they can do okay with it. Yeah.
Like you need higher doses?
I'm not sure. Do you know on the? I think they are. Yeah, I think they are using higher doses with it. Yeah. Yeah.
Do you think that it might take more life to be effective than
There's an argument for using mightat in terms of that causing adrenal necrosis. Yeah. So that's kind of the argument for using it, but trimethoprim has been used in adrenal tumours as well. Yeah. I mean, as we say, surgery is the best option for those, if at all possible. Yeah.
So one of the common questions I get asked once I've made my diagnosis is what happens if they don't treat? They always want to know how long it will live. Your classic saying, call me that's been diagnosed at 9.
The Google tells them not to treat.
Well, I
Tells
think.
them not to treat.
Yeah, no, Google does.
I mean, in some of these cases, if they can't afford all the testing,
Yeah.
we go with it. Their pensioners, shall we say, and they're quite happy
They
to
would probably
sleep with
still.
the back door open so they don't have to worry about the peeing inside.
Yeah. I mean, they would go on months to years, I would have thought.
I have found that they have gone on years. I've been quite surprised.
Yeah, no, they can do. I mean, the ones that, we're picking up earlier, so we're not seeing, everybody always talks about sort of calcinosis cutis, and I probably saw a couple of those 10 years ago, whereas I haven't seen any recently. And those were...
We had an amazing one just this week.
Yeah.
Jodie's Vetinary Pharmaceuticals. It was this huge, ulcerated, thick and crusty lesion.
Yeah.
That started off small and got really big, and it was just all manila. Yeah.
I mean, the thing with those is they don't always resolve, so you can get some improvement with it, but they don't resolve. Yeah.
Thank you very much, Robyn.
All right,
That was
you're welcome.
awesome. All good.